Hello friends, now I'm Dr. Shonali Chandra, and in this video we are going to have a recall of the OBG questions that were asked in your FMG July 2025 session. Now, what are the takeaways from this examination? First of all, there was a huge chunk of questions that came from obs-gynae. So near about 33, 34 questions had come, right? So this is a major subject which you should not take lightly at all. First of all, that you should be thorough with obs-gynae. And this is a very scoring subject, I would like to believe, and I would like to tell you that it is very, very scoring. Why? Because majority of the times it is previous year topics that are asked. Okay, so if you're thorough with the previous year topics, you should be faring well. Now, when I say be thorough, that doesn't mean just keep, ratoing or ratification or rote learning of straightforward questions that were asked. When I say be thorough with the topics, I mean length and breadth of that particular previous year topic should be very clear and crisp. So I want you to focus on the basics and the concepts again and again. Because obs-gynae is a very, very conceptual subject in the first place. All right. When they ask you hardcore gynae and obstetric questions, they're not asking you difficult questions. Let me tell you, let me remind you, yes, the difficulty level is in the close options. The difficulty level is in the lengthy stem of the question. Okay, but even when the length of the question is very long to read, you have to focus on the keywords. There are always going to be keywords that will help you rule out, eliminate incorrect options and arrive at the correct answer. Okay. And when I say that conceptual clarity is a must, because they're asking you more and more clinical oriented questions. Now, what sort of clinical oriented questions they are focusing in on? And I keep telling you again and again, they're asking questions from labor room protocols. They're asking you questions from things you see in gynae OPD, from the common reproductive conditions, right? And those are the areas that you have to focus on. So the takeaway message from this examination is that there are key focus areas, as you can see in the trend of the examination over the last couple of years. And I don't want you to go too far behind, just 4 or 5 years, and you'll realize that majority of the topics are often repeated, but you have to be very thorough with those topics. All right. So with this backdrop, let's start discussing the questions. Now, the first question, now this is also a repeat question. And let me tell you, when I'm looking at repeat questions, now the trend of the examination is such that you have to revise. You have to see the INI-CET paper. You have to see the NEET PG paper also for your FMG examination. They're leveling it up. Right? So remember that. Now, patient presents with secondary amenorrhea for 9 months after DNC. That's your first clue that there's a history of DNC. Both progesterone challenge test and estrogen progesterone challenge test are negative. So even after giving progesterone, withdrawal bleeding did not happen. Okay. Even after giving estrogen progesterone, then also withdrawal bleeding did not happen. So what is the problem? Even when we gave estrogen, even when we gave progesterone, we are not able to build up the endometrium for the withdrawal bleed to take place, right? So that's your second clue. And that is how you know that the problem could be with, yes, the endometrial lining, right? And what problem could be there? Here you have it, history of DNC. Right? So, history of DNC means high risk for Asherman syndrome, uterine synechia, scarring of the endometrial lining. So that is your answer, Asherman syndrome. In PCOS also there can be secondary amenorrhea, but with PCOS, if we give progesterone challenge test, withdrawal bleeding will occur. Right, fine. If there is premature ovarian sufficiency in which there is estrogen deficiency, okay, in which there is estrogen deficiency, then in that situation, if we give progesterone challenge test, if we give progesterone from outside, that will not be enough to cause withdrawal bleeding because estrogen deficiency is there. So PCT will be negative, but estrogen plus progesterone challenge test, when we give estrogen from outside and then we give progesterone, we will be able to build up the endometrium because deficiency was there, we are giving from outside. So estrogen plus progesterone challenge test would be positive, withdrawal bleeding would occur. So these two are eliminated. Now endometrial atrophy. Endometrial atrophy will also show, if the endometrium is atrophic, then also we will not be able to, possibly we will not be able to build it up by giving hormones from outside, but the clinical profile of the patient is going more in favor of Asherman syndrome because of the history of DNC. Endometrial atrophy will happen when there is estrogen deficiency, right? Fine. So keep that in mind. Now, moving on, next question. Oral contraceptive pill prevents against all cancers except. So this is also again a repeat question. Some way or the other they have asked you this, right? OCPs and cancers, important area. We know OC pills are protective against epithelial ovarian cancer, endometrial cancer and colon cancer also. Protective, but we know that oral contraceptive pills, they have been associated with increased risk of cervical cancer, especially in younger women, and that too not of the squamous cell cancer but adenocarcinoma of the cervix, right? So we have read about this when we were discussing oral contraceptive pills also in the main lectures and the rapid revision, and we have also discussed this in the chapter on cervical cancer when we are doing the risk factors for cervical cancer. So two places we have covered this aspect, right? Now, next question. What is the importance of the following maneuver? So first of all, there are two parts, right? What is the maneuver and what is the purpose of the maneuver? So the maneuver that is shown is the Ridson maneuver. Okay. Now, what do we do in this Ridson maneuver? Look at this. With one hand, what is happening is that we are guarding the perineum, and at the same time we are also lifting up the chin of the baby. That is what we are doing in this maneuver, all right? And with the other hand, what we are doing, we are preventing rapid extension of the head. Okay, so head delivers by extension, yes, that is correct, but we want to prevent too rapid extension or early extension of the head. So controlled delivery of the head is achieved, right? So Ridson maneuver is done in between contractions, and there is also a modified Ridson maneuver. There is also, when the Ridson originally described, there's Dr. Ridson who originally described the maneuver, he said in between contractions, okay? And there is this modified Ridson maneuver where it is done with contractions. Okay. Now, whether it is done with contractions or it is done without contractions, the primary purpose why they had devised this maneuver was that when we are lifting up the chin and we are controlling the delivery of the head by extension, right? And controlled delivery of the head is achieved, too much pressure on the perineum is avoided, right? So the importance was to prevent perineal trauma, not to prevent PPH, not to facilitate fetal rotation, and to expedite second stage of labor. When clinically we want to do that, we go for instrumental vaginal delivery. Now, when Ridson maneuver is done, okay, yes, the delivery can be expeditious in the sense that if we are going to go for hands-on delivery of the baby's head, then it could be faster. It could be achieved faster. And there have been studies, yes, I agree, there have been studies now that show that, you know, the incidence of obstetric anal sphincter injuries, or these obstetric anal sphincter injuries, meaning 3rd degree, 4th degree perineal tears, the incidence of those tears is not necessarily decreased by this maneuver. So whether or not this maneuver is, you know, helping decrease obstetric anal sphincter injuries, there are various studies in this regard. Okay, so there are studies in favor of that. There are studies who are saying that no, it does decrease the incidence of perineal tears. So we are not going to go into too much of extreme of analyzing the studies. What I want to tell you is that, simply asked, what was the importance of Ridson maneuver? The way the maneuver was described and designed, it was meant to prevent perineal trauma. So that becomes your best answer of choice here. Next question, identify the sign. Image-based question, this one is a direct repeat. It has been asked in the past. So you can see here that this is the portion that we are talking about. This is the isthmus. Okay, this isthmus is very soft during pregnancy, and you can see that there is a pregnancy inside. So these are early pregnancy signs, and we are doing a bimanual pelvic examination, right? And the two fingers, the two hands can be opposed. So this is bimanual. One hand is per abdominally, the other hand is per vaginally. That is because of softening of the isthmus. So softening of the isthmus is what sign? It is Hagar sign, right? Goodell sign is cervical softening. The cervix feels soft during pregnancy. Chadwick sign, I told you to remember with the wicked vagina, that is bluish discoloration, a bluish tinge, a bluish hue of the vagina, and the cervix is there because of increased vascularity of the tissues there. And Pisca-Seck sign is the unequal enlargement of the uterus that happens because of, you know, eccentric or lateral implantation of the pregnancy, right? So the answer here is Hagar sign. Now, looking at the next question. Now, perineal tears is very, very important. They have asked you aspects of perineal tear. I keep telling you again from labor room, right? I mean, you're delivering a baby, or you're seeing a baby being delivered and a perineal tears happen. You have to identify what type of perineal tear it is, isn't it? Because the 3rd degree perineal tears, the 4th degree perineal tears, they need to be repaired by a senior person. That is the logic why this area of topic is very, very important. So a woman sustains a perineal tear during delivery. Examination reveals that external anal sphincter is involved. It is also torn, but only less than 50%. So they are asking you question on the classification of perineal tears. What type of perineal tear is this, right? So remember here, grade 1 is the mildest. Grade 1 is the mildest, only vaginal mucosa and the skin involved, right? And grade 2 is episiotomy. Episiotomy is a type of grade 2 perineal tear, right? So 3rd degree perineal tear is when external anal sphincters or the anal sphincter complex is also involved. Less than 50% is grade 3A, and 4th degree is complete perineal tear. So answer is grade 3A. Let's look at images that will help you remember, right? So this is the 1st degree perineal tear, right? Only the vaginal mucosa and or the skin involved. This is the 2nd degree perineal tear where the perineal muscles are also involved, right? Once the anal sphincter complex is gone or involved, it is 3rd degree perineal tear, right? So this is 3rd degree perineal tear, okay, where the internal anal sphincter here is showing intact. Okay, external anal sphincter is involved. So 3rd degree is further classified as 3A, less than 50% external anal sphincter involved. 3B, more than equal to 50% external anal sphincter involved. 3C, internal anal sphincter also involved. So anal sphincter complex. And when the rectal mucosa is also torn, then it is 4th degree perineal tear. This is also called as complete perineal tear. Okay, so this can have been or this could have been an image based question also. So this is also an important area that you need to revise for your upcoming exams, right? So let's come back and have a look at the next question. Now, a mother is concerned about her 12-year-old girl developing breasts and pubic hair. So, first of all, 12-year-old pubertal development is starting. That's fine, isn't it? You counsel the mother about the signs of pubertal development. Which sign of puberty do you tell her to expect that will typically occur next? So, you are explaining her about the signs of pubertal development. So, the question is about something that has been asked repeatedly exam, the sequence of pubertal development, right? So, there is this initial growth spurt that happens, right? The first visible sign is thelarchy, breast budding, development of breast, right? So, what is the sequence? Growth spurt, but the first visible sign is thelarchy, breast development, then pubarchy. So she's already having thelarchy, pubarchy. What to expect next? Peak height velocity. And then the final event is menarche, that is onset of menses. So the answer is peak height. Okay, and axillary hair development happens along the same time that pubarchy happens. All right, next question. Which hormone is secreted by a hypothalamic hamartoma? Now, where have we read about hypothalamic hamartoma? So, there are two questions. What is it? If you know what is it, then you can have an idea. Secondly, where have you read it, right? So, a hamartoma is an abnormal malformation, neuronal malformation in this particular situation, where there is abnormal proliferation of tissue and cells. All right? So, it's not a true tumor basically. Where have we read it? When we were talking about precocious puberty, in that chapter, we had read it. Okay, when we were talking about the causes of precocious puberty, most common cause I told you is constitutional. Okay, now this is central precocious puberty. Then I told you which are the other causes of central precocious puberty. There could be CNS lesions also responsible. Okay, now which CNS lesions? There could be infective lesions, there could be CNS tumors also, and one tumor which is actually a pseudo tumor, but when one tumor I mentioned to you was a hamartoma in the hypothalamus, right? And it is responsible for precocious pubertal development. Why? Because it secretes GnRH. It secretes GnRH, okay? So, when GnRH is secreted from this hamartoma, precocious pubertal development is triggered, right? So, we get GnRH from this hamartoma and it acts on the pituitary to secrete gonadotropins, and then that acts on the ovaries to secrete estrogen, and that leads to precocious puberty. So, hypothalamic hamartoma does not directly secrete estrogen or inhibin, right? It triggers the development of precocious puberty, earlier puberty than is expected. Then the ovaries and the ovarian follicles, they start synthesizing hormones, right? So, ovaries secrete estrogen, the follicular cells secrete estrogen, the follicular cells secrete inhibin B also. So, that will happen, right? But the hamartoma itself secretes GnRH, and that is the reason why the further hormones are getting secreted. Okay, fine. And prolactin is not the answer. So, you could have gotten confused between estrogen and inhibin also, but like I told you that the hamartoma itself is hormonally active and it secretes GnRH. Now, next question. A 12-year-old girl presents with primary amenorrhea. Now, primary amenorrhea, again, questions are like hotcakes. They're often asked. This is a tough question, I agree, but then this is a repeat question. Okay, it's not an exact verbatim word-to-word repeat, and it is repeat from INI-CET and NEET PG, right? So it is not, and it repeat from recent examinations. Now you don't have to go too far. In the last year this has been asked. She has been raised as a girl, born and brought up as a girl, right? Now it is 46XY pattern. 46XY females is one topic that I discuss separately in my main lectures also. I discussed it in the rapid revision also. But then again, if you want to go into the depths of this area and the depths of this question, there is no shortcut, my dear friends. You will have to put in the effort of reading embryology, reading all of these disorders in detail, and then trying to figure out the differential diagnosis. There is no, unfortunately, there is no shortcut. I mean, I have given you flowcharts for this topic, but then if you want to remember it long term, one time effort of going through the basics and concepts from the main lectures is very, very important. Okay, so she's been raised as a girl, but she's not developed any breast. So what did I tell you? If breast development is not happening, estrogen is responsible for breast development. So I say estrogen deficiency, right? When I see 46XY pattern, I know that they're talking about gonads being testes, right? And ultrasound reveals absence of uterus. What is the most likely diagnosis? In androgen insensitivity syndrome, the gonads are testes. So talking about option 1, androgen insensitivity syndrome, 46XY karyotype, gonads are testes, right? But the gonads are secreting testosterone and there is androgen insensitivity. So that testosterone gets converted or aromatized into estrogen in the periphery. Okay, and this testosterone is not acting on the tissues because there is androgen insensitivity syndrome. And we know that in androgen insensitivity syndrome, uterus is absent. So you will get confused. You will say this is androgen insensitivity syndrome. But my dear friends, the breast development is normal, right? So breast development is normal. It is present. So it is not androgen insensitivity syndrome. MRKH syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome. What is one part of the syndrome? Mullerian agenesis is one part of the syndrome. Then you will say that uterus is absent. Okay, yes, uterus is absent, but the karyotype is 46XX. Gonads are ovaries. So this is not the answer. Okay, now Swyer syndrome. In Swyer syndrome, also what happens is that the karyotype is 46XY. Karyotype is 46XY in Swyer syndrome also, but the gonads in Swyer syndrome, the gonads are dysgenetic. Okay, dysgenetic testicular elements are there. Since they are dysgenetic, they are not secreting any hormone. Okay, so dysgenetic testicular elements, 46XY karyotype, they were supposed to secrete androgens, but they're not secreting androgens. If androgens are not getting secreted, then estrogens are also not getting secreted because androgen is always going to get converted into estrogen. No, that is the thing. Estrogen we get only from androgens. Raw material for estrogen synthesis is androgens, right? So breast development is absent. Breast development is absent. But in Swyer syndrome, the uterus is present. In Swyer syndrome, the uterus is present. Now see, this is how when you talk about it in one place, you'll have to remember that the gonads are dysgenetic because of absence of SRY gene. Absence of SRY gene is one of the reasons. Okay, so when SRY gene is absent, gonads don't become testes; they remain dysgenetic. All right. Now, in fetal life, what will happen? A person or an individual, a 46XY karyotype individual, in fetal life, if the person is having Swyer syndrome, what will happen? Think about it. Testicular development is not happening. No androgens are coming. So, Wolffian duct will not develop. right? No AMH is coming because AMH comes from fetal testes. No AMH is coming. So, Mullerian duct develops. Uterus is present. So, we have eliminated, it is not Swire syndrome. So, by elimination, answer is 17 hydroxylase deficiency. Now, let me also explain. 17 alpha hydroxylase is an enzyme that is needed for androgen synthesis. Androgen synthesis. Androgen synthesis deficiency. Okay, this enzyme deficiency, when it is there in a male fetus, in a genetically male fetus, okay. So, androgen synthesis deficiency occurred. So, that fetus was not able to synthesize androgens. Alright. So, what will happen? Mullerian duct does not develop. So, uterus is absent. Mullerian duct, Wolffian duct does not develop. Okay, Wolffian duct does not develop. So, that is one thing. Wolffian duct does not develop. Okay. Also, what will happen? There will be AMH from the testes that will come. Okay, because problem is not that the gonads are not testes. Gonads are testes. The gonads are testes, but they are not synthesizing androgens. But they are synthesizing AMH. So, anti-Mullerian hormone comes. So, Mullerian duct regresses. So, that is why uterus is absent. That is why uterus is absent. Okay. So, the answer is 17 alpha hydroxylase deficiency. So, right. So, these 46XY karyotype individuals, they are born and brought up as girls, right? When they reach pubertal development, their gonads synthesize what? No androgens. Androgen synthesis deficiency. No androgen synthesized, no estrogen synthesized. They're born and brought up as girls, but they'll have all those estrogen deficiency, right? So, they have not developed breast. They have identified with absence of uterus also. So, answer is 17 alpha hydroxylase deficiency, right? Now, let me again remind you that to discuss this, to understand this, you have to put in the effort of reading through the lectures on embryological development, 46XY females. In the main lectures, I've talked about this in detail. Without putting in that effort, this topic does not make sense. Okay. Now, in the rapid revision series, I had discussed this shortcut or a flow chart for you to attempt such questions. Let's just quickly go through it also. There's a young girl with primary amenorrhea, this sort of scenario. They could mention that she has an inguinal or labial mass, or they could also give you this extra information that the karyotype was 46XY. If the uterus is present, you mark Swire syndrome as your answer, and pubic hair is also present in that syndrome. If the uterus is absent and pubic hair is also given absent, right? You look at whether the breasts are well developed, then answer is complete androgen insensitivity syndrome. If the breast development is absent, right, and there is no virilization, it's androgen synthesis deficiency. And one of the reasons, there are various enzymes in the androgen synthesis pathway which could be responsible. Example, I gave you 17 alpha hydroxylase deficiency, right? And in INI-CET, they had given a similar scenario, and the option they had given was this one. Hypergonadotropic hypogonadism. This is a type of hypergonadotropic hypogonadism. Now, if virilization is present, meaning pubic hair development is also there to some extent or the other, and signs and symptoms of virilization are there could be two possibilities: 5-alpha reductase deficiency and partial androgen insensitivity syndrome. Okay, if they want you to differentiate between the two, they will have to give you extra information. With 5-alpha reductase deficiency, see, 5-alpha reductase transforms or converts testosterone to 5-DHT. So, if there is 5-alpha reductase deficiency, 5-DHT deficiency is there. Okay, so 5 DHT levels are going to be decreased. That means if you look at the ratio of serum testosterone to serum DHT, this ratio is going to be elevated. In partial androgen insensitivity syndrome, this ratio tends to remain normal. Now, let's look at the next question. A patient with a known marginal placenta presents for follow-up, right? So, placenta is in the lower segment, right? On ultrasound, there is a 4 by 4 centimeter placental mass. So, some part of placenta is noted. It is invading into the urinary bladder. So, ultrasound diagnosis is possible of what? Of morbidly adherent placenta, of placenta accreta spectrum, right? So, this is not just placenta previa. In addition, what is the most likely diagnosis? It is morbidly adherent placenta. Now, what part of the spectrum does it fall into? Is it accreta, increta, percreta? What is it? So, I think one of the options was increta. Okay, so this is just given twice. Let's correct it, right? So, this has perforated the myometrium, perforated the serosa, invading into the structure nearby. Since this is, must be in the anterior wall of the uterus, anteriorly it has found the bladder, that is where it is perforating, right? So, this is perforated. So, this is percreta. This is percreta. Answer is percreta. So, remember this image, right? This is here showing normal situation where there is a normal decidua basalis, right? We know that we get this placenta accreta spectrum, this morbidly adherent placenta, when we have a defective development of the Nita bush layer, right? We get an absent, which is partial or total absence of decidua basalis. So, you can see in the other set of images, decidua basalis is not there because, so placenta here is attached to the myometrium. So, that is accreta. So, it is attached to the myometrium. Okay. Then we have increta. It has gone inside the myometrium. It is invading deeper into the myometrium. Okay. And then we have this percreta, right? It has perforated the myometrium completely, right? And when it is perforating, it could have just perforated the serosa, or perforating further, it could have perforated into the nearby tissues, nearby organs, right? And also remember that antenatally, the investigation of choice, the first investigation that we do to make the diagnosis is not a plain ultrasound. Investigation of choice becomes a Doppler ultrasound. And yes, if the diagnosis on ultrasound on Doppler USG is inconclusive, then yes, of course, MRI. Okay, then yes, of course, MRI if Doppler USG is not able to make the diagnosis. And there are times that the diagnosis is a surprise diagnosis during hysterectomy. Yes, sometimes women end up with hysterectomy. Why? Because the placenta either completely fails to separate or separates in bits and pieces, and then it results in PPH, and then we attempt manual removal of placenta. So, the diagnosis can be a surprise diagnosis intraoperatively during manual removal of placenta when the placenta fails to separate in bits and pieces, or we may have ended up with a hysterectomy and final hysterectomy specimen is telling you the exact diagnosis whether it was accreta, increta, percreta, right? So, that is also possible. Now, all of this you understand if you think clinically, if you think conceptually, right? Now, let's have a look at the next question. Where is the vacuum cup applied on the fetal scalp during assisted vaginal delivery? So, now again in the lectures, in the rapid revision lectures, we have discussed vacuum application and the correct technique of vacuum application, right? So, it has to be applied where? It has to be applied 3 centimeter anterior to the posterior fontanelle. So, let's recall this with the help of the image. Okay. So let's see this image now. So this is the vacuum cup being applied on the fetal scalp, and it is to be placed in a manner that the center of the cup is at this point on the skull. Now this point on the skull is what? It is flexion point. Okay, as you can see, this is the posterior fontanelle. This is 3 centimeters anterior to posterior fontanelle, right? 3 centimeter anterior to posterior fontanelle. Or we could also say this is 6 centimeter posterior, 6 centimeter posterior to anterior fontanelle. This is the anterior fontanelle. So we could say it like that also. And when correctly applied, also have a look that the rim of the cup posteriorly, can you see posteriorly, the rim of the cup just touches the posterior fontanelle. So in short, they were asking you about flexion point. It has been a direct question in your previous exams where they have directly asked you where is the vacuum cup applied, or what is correct application, where should be the center of the cup, of the cup should be at the flexion point. Now this time they ask you the question to describe where is the flexion point, right? So this is how they have asked the question. So it is applied 3 centimeter anterior to posterior fontanelle, so that the center of the cup is at the flexion point. So in short, they were asking you about the flexion point. Now, recalling the next question, patient have variable deceleration on CTG. Again, CTG interpretation, very, very important. Types of deceleration, very, very important. I keep telling you, this could be image-based questions, these could be direct questions. What does that indicate? So, variable deceleration indicate umbilical cord compression. With fetal head compression, we are getting early decelerations, right? And with uteroplacental insufficiency, we're getting late deceleration. Maternal hypotension can also lead to uteroplacental deficiency and can trigger late decelerations. Okay, so uteroplacental insufficiency, the various causes of uteroplacental insufficiency or fetal hypoxia can cause late deceleration, right? So, variable decelerations are seen because of umbilical cord compression. That is why patients with oligohydramnios, okay, they have more risk of having variable deceleration, because with oligohydramnios, chances of cord compression increase, right? Now, next question. In a case of face presentation during labor, what is the engaging diameter of the fetal head? Direct question, answer is submentobrygmatic. So, there are 2 diameters which can be there when there is a face presentation. I always tell you to remember submentobrygmatic. This is 9.5 centimeter diameter, and another can be a submentovertical diameter is also possible, but that is not in the option, and that confusion isn't here. Just to remember with the image, can you see here? This is the submentobrygmatic diameter. Submentobrygmatic diameter, which is the engaging diameter of the fetal head, and submentobrygmatic diameter happens when the head is completely extended. Diameter when the head is completely extended. Okay, fine. Now, next question. What is true statement regarding endometrial hyperplasia? Now, there is a discrepancy here, in the sense, discrepancy in the recall here, as to whether they had mentioned endometrial hyperplasia or they were asking about endometrial pathology, or they had mentioned endometrial pathology. Whatever, the answer would not change. Okay, so they are talking about, let me give you a context also. Possibly context was there in the exam, but we don't have it as a part of the recall. So this is a difficult question. Again, it asked you to analyze and attempt an answer and use logic, right? So the context would be of abnormal uterine bleeding. That is where we are thinking about endometrial hyperplasia. That is where we are thinking about endometrial pathology, right? Now, what sort of endometrial pathologies are we expecting? Now, endometrial pathologies could be endometrial polyp, endometrial pathology could be endometrial hyperplasia. Remember the Palm-Cohen system of classification? That is what we are talking about, right? Now, the gold standard for diagnosis of endometrial pathology or even endometrial hyperplasia is hysteroscopic biopsy. That is the best true statement here. That is the one true statement here. We're talking about the gold standard. Yes, we can go for an office endometrial sampling. Office-based or OPD-based endometrial aspiration, that can be done. Right? In fact, that is the first step we do to pick up endometrial pathology, to pick up endometrial hyperplasia. But again, it will make the diagnosis in most cases, but it can be falsely negative also. I mean, I've discussed this in AUB in the main lectures. I've discussed this in postmenopausal bleeding also. The concept here is that, let's just understand here. Let's just see that if this is the uterus here, and we're talking about endometrial pathology. Any endometrial pathology that will be global. Global meaning that the pathology is involving the entire endometrial lining. Okay, so you go blindly without any vision. Without visualization, when we go blindly with the, we may go blindly with the cannula. That is endometrial aspiration with the Pipel cannula. We may go blindly with the DNC also, with the curettage also, right? But a DNC will be just, more aggressive. It will be, let's say, you'll have to dilate the cervix and then go for a curettage and, curetaging, nooks and corners of the endometrial lining. We may be missing some areas while curating the endometrial lining. With the Pipel cannula, when we are aspirating, all of this gets aspirated. Okay, that's why the aspiration technique, cannula based aspiration technique, Pipel cannula, endometrial aspiration we call it, is definitely better than dilatation and curettage. Dilatation and curettage, I mean, can be used for diagnosis only if aspiration techniques are not available, right? So I'll say, okay, this is fine. But in current clinical practice, this is not used for making the diagnosis. So I will not take it as a true statement completely. I will not be in favor of DNCs used for diagnosis particularly. It can be done, but only in certain situations where aspiration is not possible. And in these days, endometrial aspiration is what we are doing as our initial investigation. So what was I telling you? That if the pathology is involving the entire endometrial lining, when we suck out the endometrial lining with aspiration, we are going to make the diagnosis. But there can be cases where there is focal pathology. There can be cases where there is focal pathology. There can be cases where hyperplastic areas are also focal. It's possible. Okay, there could be areas in the endometrium which are hyperplastic and areas which are not. That's also possible. There could be other focal pathologies like endometrial polyps is a focal pathology involving particular areas of the endometrial lining. So hysteroscopic biopsy, go inside, visualize the endometrial lining and biopsy the abnormal areas. That is why women who continue to have abnormal bleeding, even after a negative endometrial sampling report, don't we do hysteroscopy for them? Even when she has persistent abnormal uterine bleeding or persistent postmenopausal bleeding, and we have a negative endometrial aspiration report, we suspect that we may be missing something inside. And then we go for a hysteroscopy. So hysteroscopy is the gold standard. Okay, hysteroscopy, not hysteroscopy alone, but hysteroscopic biopsy is now considered the gold standard for evaluation of endometrial pathology, or in certain situations where hyperplasia may be focally involving the endometrial lining, and we may have missed. Unfortunately, we may have missed in the initial endometrial aspiration report. Isn't it? So yes, gold standard for diagnosis is hysteroscopic biopsy. So I will prefer option A as the better true statement rather than DNC is used for diagnosis. If biopsy is done, no other follow-up is needed. No. If biopsy is done and we have a follow-up. Follow-up will depend upon what is the report of the biopsy, what type of endometrial hyperplasia is it, that will decide the follow-up, isn't it? And even if negative report, we do want to follow up, because if she has persistent symptoms, we may have missed. So this is also not right. And no biopsy required for recurrent symptoms. No, if recurrent symptoms are there, then obviously repeat biopsy, hysteroscopic biopsy, that is done, right? So this is the closest recall that we have of this question. The point is that this was a difficult question to recall also from the students coming, that because there was a lot of discrepancy in this question, but I've tried my best to give you the gist of what was being asked in the question. The very basics of detection of endometrial pathology were being asked in this question. Now the next question. So a woman with previous cesarean section is in labor. She's getting 3 contractions in 10 minutes. So this is fine, isn't it? This is a good contraction. This is fine. There is no fetal distress. That's also good. The membranes are intact. Her partograph is shown below. Now, what was the partograph like, right? What does the recall tell us? The recall tells us, now I'm not very sure if it was 4 centimeter or if it started at 5 centimeter, where it was starting. But what we recall from you people is that the alert line had been crossed, and it had been 4 hours. It had been 4 hours and the alert line had been crossed, not the action line. Okay. So it was, yes, slow progress. It was, yes, slow progress. Despite adequate contractions. Despite adequate contractions. Okay. So action line had not been crossed. That is why I won't say proceed with cesarean section directly, right? And proceeding with instrumental vaginal delivery, you don't know, no other finding has been given to you. Action line is not crossed. Intervention is not needed right now at this point in time in the form of expediting delivery or going ahead and delivering the patient. That sort of active intervention is not needed. And whether instrumental vaginal delivery will be possible or not, even though if it's a previous cesarean case, it will depend upon the PV findings, and those were not mentioned in the question, right? So this is out. Now starting oxytocin infusion, there are 2 reasons why I will not start oxytocin infusion here in this case. A, they have already given that the contractions are adequate. That's reason good enough not to start oxytocin. Secondly, we have to be very cautious. They've mentioned previous cesarean section. So these 2 clues were enough for you to rule out that starting oxytocin infusion is not going to be harmful. In fact, it can be dangerous. In fact, it can be detrimental. Okay, so this is something that you should not do. What you could do in this situation is to perform an ARM. What you could do in this situation is perform an ARM. How would that help you? If you performed an ARM in this situation, it would, yes, spontaneously tend to, some increased uterine contractions also. If you do an ARM, this is a previous cesarean section case also, you would now be able to note the color of the liquor. So the chances of having meconium stained liquor are there. This is a high risk labor situation, no? So the chances of having meconium stained liquor are there. The chances of detecting blood stained liquor or abruption or bleeding that can happen when there is a scar rupture. So ARM becomes helpful because of many reasons. And before the decision for arrest of labor for cesarean section is taken, if this is something that you would see if you had done labor room postings. If you have done labor room postings, you would know that before taking up a patient for cesarean section, there are few certain steps that your resident takes. Okay, what does your resident pick up during a laboring woman's follow-up? While they are monitoring the patient, they are noting the progress of labor, they are plotting the partogram, they are noting the fetal heart rate, they are noting the maternal vitals and everything. They are seeing if labor is proceeding as normal or not. If the contractions are not adequate, they will tend to, increase oxytocin. If the contractions are inadequate, they will do the PV, they will note the PV findings, they will do an ARM again to increase the contractions. If they find that there is fetal distress happening, they will also do ARM. They will do the ARM, because ARM, when you do the ARM, at the same time, you are also noting the PV findings also, right? So this decision making happens day in and day out when we are, monitoring our laboring patients, right? So before taking up a patient to cesarean, before deciding upon the mode of delivery whether I have to deliver by cesarean, whether instrumental vaginal delivery is possible, we always have to examine the patient. Perabdominally, we will examine, fetal heart rate we will check, contraction we will check, PV we will do, look at the cervical findings. At the same time, membranes will be there or not, we will see. If bag of membranes is there, we will do ARM, we will note the color of the liquor, we will complete our examination. Then in totality, we will decide what should we do, should we give her more time, isn't it? Should we, go for what sort of action we should take, what sort of intervention we should do, then we should decide, right? So, based on the partogram, this was slow progress, yes, but nothing, A, B, C were not fitting into the management that you would do, so you would perform an ARM. Like, for example, if you were in this situation and you had to wait for your senior, you had to call your senior. If you have done the labor room posting, you will inform these findings to your senior. Senior would say, do PV, tell me the PV finding, do ARM, tell me the findings, what is the liquor, liquor is clear, liquor is what, right? Meconium stain, blood stain, what is it, right? So you would do ARM, right? So that is your answer for this question. Now let's look at the next question. A patient develops profuse uterine bleeding after a lower segment cesarean section. Oxytocin has already been administered, but bleeding continues. What is the next best step in the management? Okay, so this is again very clinical oriented. If you have gone through my main lectures, I've had discussed a similar question with the questions in my, the questions that I discussed in the end of my main lectures, right? A similar looking question. So yes, profuse uterine bleeding, PPH is happening. All right. From the recall that we got from the students, it is not very clear whether they mentioned atonic PPH or not. Some people are saying they mentioned, some are saying they did not mention. Doesn't matter. So it is PPH. Let's assume most commonly it is atonic PPH, right? And it is happening on table. Cesarean section we are doing, okay, and we delivered the baby and then we give the oxytocin as we are supposed to do in the active management of third stage of labor, and then, PPH is happening. So we must have done the initial management. What is the initial management? You give the uterotonics. So we have given oxytocin and the bleeding continues. What is the next best step in management, right? So do we proceed with hysterectomy straight away? Of course, you would agree that that is not something that to be done, right? Do we go for devascularization procedures? What are devascularization procedures? Uterine artery ligation, then ovarian, and then internal. So stepwise devascularization is one thing. Now, what did I tell you? That it becomes time consuming, isn't it? And most likely this would have been atonic PPH. Most likely this would have been atonic PPH. Yes, if there is bleeding only from the stitch line, okay, then it can be tackled by a uterine artery ligation, right? So that is not clearly mentioned. So I will say I will not prefer devascularization procedures, right? And I told you in the lectures also that in the face of atonic PPH, this profuse uterine bleeding, uterine compression sutures are more better. Then you could argue, why not uterine balloon tamponade? Okay, balloon tamponade can be done during cesarean section also, but please understand, balloon tamponade is mainly done in vaginal deliveries, okay? And why? As a means of temporizing measure, one is that. Secondly, obviously, we want to avoid a laparotomy, okay? Fine. So if the tamponade is successful, we avoid a laparotomy, we avoid a surgery. The patient is already on table, already cesarean section is being done, already abdomen is open. And that's why we want to have a quick response. So what is quicker than that? You are on table. And let me tell you one thing, again, if you're not able to make sense of it, if you have gone through your OTs and postings and everything, and if you had the chance of seeing PPH happening in the OT, you will realize that once the uterotonics are not working, the next reflex or the next impulse that we have is to go for a compression sutures, right? So uterine balloon tamponade is also not preferable. I would say the next best step in management is compression sutures, right? So that is why, because she is having this unresponsive PPH during cesarean, I would say go ahead with the compression sutures as the next best step in management. Now, next question was an image-based identification question. This is an image. Similar image has been shown in the lecture. Similar image has been shown in your rapid revision videos, and similar image is in your textbooks as well. Right? And this is an image of uterine inversion. Uterine rupture, if it would be there, that would not be something coming out of the introitus, right? It would present in a different clinical scenario altogether. If it's a cervical polyp, where is the cervix? If it's a polyp coming out of the cervix, where is the cervix in this image? This is not the answer. This is not the answer. Vaginal vault prolapse, you could have gotten confused. We are not sure if they gave a clinical context with this. Even without a clinical context, if they had just asked directly identify the image and nothing else was provided as a clue in the question, this is not a vaginal vault prolapse, which you could have gotten confused with, because when there is a vaginal vault prolapse, the inside of the vaginal lining prolapses out. When the inside of the vaginal lining prolapses out, you will see the vaginal mucosa, the bright pink vaginal mucosa. Or if it's an old lady, it will be an atrophic vaginal mucosa, pale looking vaginal mucosa. But what are you seeing here? All of this reddish mucosal lining. This is the endometrial lining of the inverted uterus that you are seeing. Okay, so this is uterine inversion, inverted uterus, uterine inversion. So the inside lining, this inside lining, endometrial lining, the decidua now in this particular case, this rough looking, reddish looking decidual lining is what you're seeing, and this is uterine inversion. Now, moving on to the next question. A pregnant woman is seen at 33 weeks, 4 days. She is admitted with preterm labor. Which drug should be administered to the woman? Okay. So, what do you think is the priority drug to be given? She is in preterm labor. The one drug that is most important right now is the drug to promote pulmonary maturity of the fetus. Which is that drug? Drug of choice, you all know, dexamethasone. Another drug that we use is betamethasone. Both are fine. Both are equally efficacious. For us, drug of choice is dexamethasone. What are these drugs? These drugs are corticosteroids. Steroid cover, we keep saying. Right? So, less than 34 weeks, preterm labor, established preterm labor, likely to deliver preterm labor, we have to give steroid cover. We have to start with steroid cover. Progesterone is not a tocolytic. Progesterone has a role in prevention of spontaneous preterm birth in high-risk pregnancies. Progesterone has a role in prevention of preterm birth, of spontaneous preterm birth in high-risk pregnancies. What are those high-risk pregnancies? Maybe women with history of prior spontaneous preterm birth or cervical length shortening. There is a role of progesterone therapy for women, and this progesterone therapy is given throughout pregnancy, right? So the thing is that it's not given when the patient is already in preterm labor, established preterm labor. So once contractions are there, you don't give progesterone. Progesterone is not a tocolytic. So this is not given. Indomethacin is a tocolytic. So you may think we want to give tocolytic, but you know, tocolytic, yes, you may want to give a tocolytic, but indomethacin is something that we would not want to give. Why? Because this is not your answer. Why? Because indomethacin is not given beyond 32 weeks. Why? Because it can cause premature closure of ductus arteriosus, and we don't want that. So, if you want to give tocolytic, indomethacin is the tocolytic that you will not give. And anyways, for us, the drug of choice, tocolytic of choice is nifedipine, right? So, indomethacin, if you get confused, you were confused between indomethacin or corticosteroid, to give tocolytic or not give tocolytic. That's not the question. The question is, see, the question is not whether, you don't have to choose whether you have to give tocolytic or not give tocolytic. The question is clearly asking which drug should be administered. So, don't overthink the question. The priority drug that you need to give is steroids. Even if you're thinking about tocolysis, indomethacin is something that you will not give. She is already more than 32. So beyond 32, we do not give indomethacin. Right. So again, one thing that you learn from this is that you do not overthink on the question. All right. And magnesium sulfate is given for neuroprotection for the fetus, right? For the newborn that will the newborn will have, for prevention of cerebral palsy in the newborn. So neuroprotection of the fetus, magnesium sulfate can be given, but it is given in extreme prematurity. Right, like when the pregnancy or when the woman is in preterm labor at less than 30 weeks of gestation. She is already 33 plus 4. Magnesium sulfate, no role right now. This should not be administered. So at your level, if you were in this situation, priority drug that you would give is steroid cover. That's your answer. Now, next question. A 38-year-old woman, para 2, live 2, with severe endometriosis. She has been on medical management. She's undergone laparoscopic tubal ligation and adhesiolysis previously. Right, so she's on medical management and adhesiolysis has also been done, and at that time tubal ligation was also done. So family is complete. She now returns 6 months later with recurrence of symptoms. So she's not responding to medical management. The initial adhesiolysis surgery was done. She's not even responding to that. So recurrence is there. Now what is the next best step in management? So observation and no intervention is out because she's having recurrence, right? Now, you have to choose between the 3 surgical options that are given to you. Okay, so because she is 38-year-old, I mean 36, 38, whatever, she was less than 40 years of age basically, you will not go for a oophorectomy. I would not prefer to go for a oophorectomy. Yes, I can go for a total laparoscopic hysterectomy because she's already undergone a tubal ligation and she must have been willing for a tubal ligation. So I'm assuming that yes, of course, her family is complete. No, that's why. So we can go for a total laparoscopic hysterectomy. Okay. And when I say hysterectomy, how is it beneficial? Because it will prevent the retrograde menstrual flow. And the retrograde, that is the most common theory, isn't it? So it will get rid of, or it will prevent the retrograde menstrual flow will not happen. So new seeding of implants will not happen. So that is one way that this is helpful. However, there are other theories also for endometriosis. So, yes, of course, some people recommend that, oophorectomy should also be done at the same time. But again, the woman is young. So that's why I'm not preferring a salpingo oophorectomy. What we can do in these situations is go for a total laparoscopic hysterectomy and then keep her on ovarian suppression with, long-acting GnRH analogues. They can be continued after surgery. At least that can be tried. So this was, yes, a difficult question. This was, yes, a question which went one step beyond what is usually asked of FMG students in cases of endometriosis. But yes, if you've left this question, it's fine. But if you wanted to attempt, there were clues given in the question which would have made you choose total laparoscopic hysterectomy since she was young. I don't want to sacrifice her ovaries as of yet. Okay. Moving on to the next question. Straightforward question. Woman has been diagnosed with following uterine anomaly as shown in the figure. So you had to find out the uterine anomaly. Even if you didn't find the uterine anomaly, you would have known that these are Mullerian anomalies. You would have known that these are Mullerian anomalies. So the crux of the question is identification. This, they had shown a unicornuate uterus, right? This is the rudimentary horn. This is a rudimentary horn, and only one side paramesonephric duct was developing. So the question was first of all on identification. Defective development is of which embryological structure is responsible for this pathology. So which embryological structure you had to identify? This was a Mullerian anomaly. What is the name of Mullerian duct? Paramesonephric duct. Mesonephric duct is Wolffian duct. It regresses in females, and metanephric duct is the initial duct that forms when the renal system is developing, right? So it is paramesonephric duct. Straightforward answer. Only thing that you had to do was identify what was shown in the image. Next question. Which hormone is responsible is responsible for development of B and C. Now, this is a image of the breast tissue. So, first you had to identify what they are showing you, B and C. So, C is the lactiferous ducts and B are the alveoli that are shown. Right. Now, again, the discrepancy that I have here from the recall is whether estrogen and progesterone was given as a same option, or whether estrogen and progesterone was given as two separate options, right? So, let's just have a look at both, right? So, GnRH directly not responsible, oxytocin not responsible, prolactin not responsible. Prolactin is responsible for milk synthesis, oxytocin is responsible for milk ejection reflex, and GnRH we know acts on the pituitary to secrete gonadotropin. So, estrogen and progesterone are responsible for development of ducts and alveoli. What if they were given as separate options? Okay, so ducts are developing in response to estrogen and alveoli are developing in response to progesterone. In response to progesterone, but after estrogen priming. Meaning, first estrogen primes the alveoli. First estrogen acts on the tissues and then progesterone leads to the development of alveoli. So, it happens after estrogen priming. So, if estrogen and progesterone were given as separate options, you would choose estrogen as the answer. I would have chosen estrogen as the answer if they were given as separate options. Now, next question. After an initial serum beta HCG test in a patient with suspected pregnancy, when should the repeat beta HCG level ideally be checked to assess the viability of progression of pregnancy or viability of pregnancy? So, we have a suspected pregnancy, meaning UPT must be positive. We have a pregnancy of unknown location. We have to check the viability. Right, we know that in viable intrauterine pregnancy, there is doubling of HCG that happens and doubling time is every 48 hours. So, we should be checking the serum beta HCG every 48 hours. Right. So, this is a fair enough direct question. We have discussed this multiple number of times in the lectures, in the rapid revision, also in the main lectures. Next question. Dual testing for screening of Down syndrome incorporates which of the following? So, we know that you would have gotten confused with NT. When we say combined first trimester screening, okay, remember we have done this in rapid revision also, in main lectures also, combined screening. NT is done along with, NT is on transvaginal sonography, serum beta HCG and serum PAP-A. This is what we generally do, right? So, this is serum tests. If only these two are done in the first trimester, this is the dual test. Dual test is serum test. So, yes, PAP-A and HCG is incorporated into the dual test, not NT-HCG, not NT-PAP-A, not HCG-AFP. AFP is a part of the second trimester screening, serum analyte based screening. So, AFP becomes a component of triple test and quadruple testing, right? So, this is straightforward, PAP-A and HCG. Next question. A woman presents with spotting in early pregnancy. A transvaginal sonography is performed. What would be an indication for pregnancy termination? Right. So, spotting in early pregnancy could be because of early pregnancy loss, which is an ultrasound diagnosis. That is how we end up diagnosing early pregnancy loss these days. I have discussed with you a number of times. Such a situation is what was previously called as missed abortion, right? Now, this is going to be early pregnancy loss, meaning it is a non-viable early pregnancy. So, if it is non-viable, there is no point continuing. Okay. Yes, these patients present with spotting. They could start the process of spontaneous expulsion on their own also, but it becomes an indication for pregnancy termination. So, whatever they are asking you, what have we discussed again and again? How do we diagnose Early pregnancy loss on ultrasound, and I've told you two parameters, CRL more than 7 mm, and yet there is no cardiac activity. That is your answer. Another parameter that I asked you to remember was mean sac diameter, gestational sac, mean sac diameter more than 25 mm, and it is still empty. That makes the diagnosis of early pregnancy loss, early pregnancy failure. Mr. Boshan also we call it. Now, next question. Okay, now pregnant women with short cervix undergoes a cerclage procedure. They had given you an image and you were asked to identify. Many times, and this is what has been asked of you people in exams, is the McDonald cerclage, because that is what we commonly do. Shirodkar cerclage is something that you would not have seen being done in front of you because we're not generally doing it, right? And again, this is unfortunate. This is a little bit tricky of the examiners to ask you this question. And if you've not attempted it, if you had any doubt and you've left it, it's fine. So what we got from the recall was that it didn't look like McDonald's. You guys were certain of that it didn't look like McDonald's, because McDonald's we have a suture. Okay, here there was a tape. It's not about suture and tape difference particularly. The difference is in cervical dissection. So what I've told you in the main lectures is that yes, McDonald's is something that is technically easier, very effective, and that is what we do. And in that, cervical dissection is not needed. Shirodkar cerclage, the difference between McDonald's and Shirodkar's is Shirodkar cerclage is placed higher on the cervix, higher up on the cervix. Okay, so let's say this is the cervix. McDonald's is placed here. As high as we can go from vagina and as high as we can go, we place it, right? If you want to place it a bit higher on the cervix, that is going to be Shirodkar's, right? But that is only possible, and Shirodkar's is also vaginal cerclage. Shirodkar is also done by the vaginal route, but for that, dissection has to be done. Dissection is done on the cervix, right? This dissection that you see in the image, this dissection is done so that we can separate the bladder. We can lift up the bladder and we can go higher up in the cervix. Okay. So, Shirodkar's, the main difference between McDonald's and Shirodkar is that cervical dissection is done and the suture or the cerclage is placed higher up on the cervix. Now, this could be a suture, but these days tapes are also there. So, like I said, tapes and suture is not the difference. The difference is in the technique, right? So, this is, now what is this? Is this Shirodkar or is this modified Shirodkar? Now, in Shirodkar, what happens is that this is the tape. This is a Marceline tape. This is a tape made of Marceline. Shirodkar originally suggested it. He would tie this tape here. He would tie this tape here. And originally he had tied it posteriorly, then people said that, so originally he had tied it anteriorly, and then people said that the knot is very thick, it erodes into the bladder, so they wanted to place it posteriorly. So anterior posterior knotting and all that was there, right? So many modifications happened, but the other modification of the what is called as modified Shirodkar is that the entire tape is buried. Okay, the dissection that is done, the flap that was raised is all closed off, right? So, the entire suture or the entire tape is buried. And no knot is left pouting out, because when the knot is left pouting out, anteriorly is the bladder, it erodes on the bladder. So, they started putting the knot posteriorly. Then they decided that let us bury the knot altogether and then bury the entire tape altogether. So, the answer to this question was modified Shirodkar's. And this was definitely a tough question, definitely a question beyond, I would say, even NEET PG level or undergraduate level, right? So, this is a tough question. If you've left it, I think it's fine. But now that it has been asked, once. Please try to remember it, that this can be a potential question for upcoming exams, and we know that they are fond of asking these images. Now again, this image that they had picked up, most likely if this is the image that we got from the recall, I think they wanted to see if you have opened textbooks, because this image definitely is given in textbooks, right? So this here on the left is McDonald's, where there is a stitch, as you can see here, and there is no dissection can be done. There is a stitch and there is no dissection on the cervix that is done. And this here is modified Shirodkar's. And like I told you, why is it modified Shirodkar? Because the entire tape is buried. Okay, because if the knot is left outside, it was found that it led to erosion and it increased risk of infection, and also it would erode into the bladder. Increased risk of infection was definitely there, so they started burying it. So this is modified Shirodkar. But please remember, difference between McDonald and Shirodkar is it is placed higher up and dissection of the cervix is done, and that is the modification, is that the entire tape is buried. Now, next question. A 25-year-old woman presents with lower abdominal discomfort and an adnexal mass. Image of the ovarian cyst removed is shown below. What is the most likely diagnosis? So, classic image-based spotter, right? We can see these the inside of the cyst filled with these embryological structures, which are mature elements. Isn't it? These are mature elements because we can see these developed hair and these cartilage, right? And this is the Rokitansky protuberance, solid areas, right? Cheesy material. So a classic representative image was given to you, right? An image that you have seen, and this is an image which is obviously recall image. So this may not be the exact image that you got in your exam, but it was fairly clearly obvious that it is a mature cystic teratoma. The only thing that you could be confused here was you not remembering the name. This is dermoid cyst. Okay, so serous cyst adenoma is a benign epithelial ovarian tumor, benign because oma, and it would be filled with serous fluid, right? Immature teratoma would be solid cystic areas will be there. It is also a malignancy. It's a germ cell malignancy, immature teratoma, and inside the elements are not mature. So this is not. And endometrioma is an endometriotic cyst. Chocolate cyst we call it, right? So chocolate colored fluid, that looks different, right? We've seen these images in the lectures, right? Rapid revision and everything. Now let's look at the next question. A patient presents with obstructed labor, or whether obstructed labor was mentioned, whether prolonged labor was mentioned, and on abdominal examination, a groove or band is palpable across the uterus. What is this ring called? Straightforward question. If the ring is palpable across the uterus, meaning palpable per abdominally, palpable per abdominally, and the clue is obstructed labor, it is Bandel's ring, which is the pathological retraction ring, which is seen in obstructed labor. Constriction ring is the Schroeder's ring, which is not felt, is the same. It is not felt per abdominally, it is felt on PV. Okay, and contraction ring is, we don't discuss this separately, so that is not correct, right? Contraction ring is just the physiological, basically, ring that is there between the contracting upper segment and the lower uterine segment that is undergoing receptive relaxation. So that demarcation is the contraction ring. That's very physiological, right? So that is physiological anyway, so that is not your answer. So this is not the answer and this is not the answer. Now the next question, which you should know, it is direct question. What percentage of fixative is used to do a pap smear? It's 95% ethanol. Repeat question. Next question, what is co-test in cervical cancer screening? What is co-testing? Yes, HPV and PAPs, when done together in the patient, is called as co-testing, right? So remember, HPV and PAPs, not via PAPs, not HPV via, not PAPs plus colposcopy. Colposcopy is not part of the screening at all, right? And the PAPs that is done, When we do a co-test, please also remember one extra pointer. We take the sample, the same sample, liquid-based cytology sample. The same sample we use for the cytology, and the same sample can be used for the HPV DNA testing. Okay, liquid-based cytology sample which we collect in the fixative, right? And please also remember that the fixative for, okay, that question has already been discussed. Fixative for liquid-based cytology is not 95% ethanol, it is methanol. Okay, so when they're talking about fixative used to do pap smear, when they're saying ethanol, this is for conventional pap smear. This is for conventional pap smear where slides are made, right? By when we are taking the pap smear, we immediately make a slide and we do not allow the slide to air dry and put it in the fixative. That is conventional pap smear. Another pap smear technique is cytology. Okay, so when we take the liquid-based cytology sample, that same sample can be subjected to HPV and PAPS testing, that is co-testing. And if we have to do co-testing, because HPV DNA testing, please remember, HPV DNA testing is only recommended beyond 30 years, more than equal to 30 years. So if we have to do co-testing, we have to make sure that the woman is more than equal to 30 years, because HPV DNA testing is recommended only beyond 30 years. So co-testing is also recommended beyond 30 years of age, right? And if we have to repeat co-testing is also repeated every 5 years. Okay, every 5 yearly co-testing will be repeated, just like HPV DNA testing. Now, next question, which again you people found difficult. Again, it is, I would say, a tough question, considering to ask you or to expect students to mug up the Bishop scoring and remember it at verbatim to attempt this question in a go. So I think majority of PU people left it, but I will also tell you, there could have been, you possibly could have attempted it, right? Now, a pregnant woman is being assessed for induction of labor, cervical dilatation of 2 centimeter, which is a good enough dilatation. Let me just tell you, right? 2 centimeter is good. 0 is closed, right? Then 1 to 2 centimeters, so score is better, isn't it? Effacement 50%, already partially effaced. Soft cervix, very good. Mid position, it's not posterior, it's good. Station, +2. So each of these findings, if you see, were very favorable independently. So my best guess, I may not be able to say whether the score is 7 or 8 or 9 or 10 or whatever, but I would at least be able to guess that it is favorable. So I would be able to choose score 8 as the answer. Okay, does not seem unfavorable to me. And highly unfavorable, to obviously not, does not seem unfavorable to me. And score 6, borderline. So at the most you could have gotten confused between favorable or borderline. And I would just say, why would the examiner ask you about a borderline score? It makes no sense. So working by that logic, I would have gone for favorable. Okay. And if you did not attempt it, I would say that it is also okay. But let's just have a look at the Bishop score, right? Let's just have a look at the Bishop score. Okay. And let's just see. 2 centimeter dilatation is here. So score of 1. Effacement 50%, score of 1. Station is +2, that gives a score of 3. And soft gave a score of 2. And mid position gave a score of 1. So this would be 5, 6, and then 8. Right? So again, like I said, that you could have worked out the score like this, but it would have been very difficult to attempt this question in a minute, because you have a load of questions. So if you left it, fine, but if it could have been, you can consider it as a trick question. Considering that most of the findings were favorable, I would go more in favor of picking up favorable as the answer. So I wouldn't say that the question was not doable. It was doable, but it is okay if you couldn't do it. So don't you should not be thinking that this was an easy question. It wasn't. It was a trick sort of a question. Next question. Doppler assessment of which artery is used to determine fetal anemia? Repeat question. So, umbilical artery Doppler, ductus venosus artery Dopplers. These are Dopplers that are done for evaluation of a growth restricted fetus, isn't it? So, umbilical artery Doppler is for evaluation of fetal growth restriction, growth restricted fetus, and also in those situations for timing of delivery. Ductus venosus also has a role there. It is showing pre-terminal findings, impending death, right? Uterine artery Doppler is entirely different, right? Uterine artery Doppler, again, we have it for prediction of preeclampsia, for prediction of fetal growth restriction. That is where the role has been discussed, and the answer to this question is middle cerebral artery, right? So the logic is for fetal anemia, when there is fetal anemia, whenever there is anemia, we know that there is hypoviscosity. Blood flows faster. More blood goes to the brain. Blood flows faster. More blood goes to the fetal brain, and faster blood flows are there. That is seen in middle cerebral artery. So that flow of blood flowing faster is what we see. Middle cerebral artery peak systolic velocity, more than 1.5 multiple of median, is what predicts fetal anemia, is for early detection, of fetal anemia. Where have we read this? In RH affected pregnancy, right? Next question. During the management of shoulder dystocia in childbirth, which of the following is the earliest and first maneuver that is attempted? Mac-Robert maneuver, again a repeat question. Shoulder dystocia, signs of shoulder dystocia, Mac-Robert maneuver, right? So Mac-Robert maneuver could be an image-based question. It has been an image-based question most of the times. Remember, this is the earliest and the first maneuver that is attempted, right? We ask the woman not to push, we do not pull from below. So not to push, not to pull, call for help, immediately hyperflex the thighs onto the maternal abdomen and also abduct the thighs at the same time. To this, we can add suprapubic pressure given by the attendant, right? Rubin's maneuver, and corkscrew maneuver, they are Wood's corkscrew maneuver. These are internal rotational maneuvers. They come next. Okay, so delivery of the posterior arm, internal rotational maneuvers, they come next. Okay, clidotomy is fracture of the clavicle, comes, these are the maneuvers of last resort, and Zavanelli procedure, again maneuver of the last resort. So obviously answer is Mac-Roberts maneuver. OC pills can be given in which of the following condition? Where is it safe according to medical eligibility criteria category 1? So what is this medical eligibility criteria? Category 1 means it is absolutely safe. No concern at all for the method. Absolutely safe to use, right? Category 2 is that we could use the method. Benefit are more. Okay, we could use. Category 3, we generally don't use. Why? Because the risks are more. And category 4 is absolutely contraindicated. Now what they are asking you? OC pills can be safe. Criteria 1, absolutely safe to use. Do you think it is absolutely safe to use in hypertensive? Time and again I told you these combined methods are not used in hypertensive women. I don't prefer to use. In diabetic, we don't prefer to use. In hyperlipidemia, we don't prefer to use. So it is absolutely safe to give in HIV positive women. Okay, so HIV positive women can be prescribed oral contraceptive pills. Even women with HIV on antiretroviral drugs. There were concerns earlier that oral contraceptive pills and antiretroviral drugs, they could have drug interactions. But now they are saying that that is also not entirely true. The dosage of oral contraceptive pill, the dosage of estrogen is less now. Okay, we have low dose oral contraceptive pills that we are routinely using, so the chances of these drug interactions are minuscule, right? So we can use oral contraceptive pills even in women who are on antiretroviral drugs also. They are not contraindicated, right? So HIV, it is safe to give. It's medical eligibility criteria number 1 if she is not on any antiretroviral drugs, okay? Or even if she is on antiretroviral drugs, it is medical eligibility criteria category 2. So nonetheless, it is safe to give, okay? Next question, use of implant, a form of long-acting reversible contraception. So, which form of implants are they talking about? They're talking about progesterone implants because that is what we are using, or that is what they are making available to us in the market, right? So, it is contraindicated in which condition, right? So, this is progesterone implant, okay? So what first of all you should know was that when they're talking about implants, they're talking about progesterone implants, okay? And the only 2 absolute contraindications that I have taught you about progesterone, whether they are progesterone implants, whether they are injectable progestins like DMPA, whether it is progesterone containing intrauterine device like Mirena. They are absolute contraindications to progestins in general. There are 2. Undiagnosed vaginal bleeding, a history of vaginal bleeding that has not been investigated and not been diagnosed as to what it is, and breast cancer. These 2 are category 4 for the use of implants, right? And please remember that progesterone only methods, they are otherwise freely used in conditions where estrogen is contraindicated. So hypertension, diabetes we could give. PID also we can use implant. In PID, intrauterine devices, active PID, not history of PID, active PID, intrauterine devices are not indicated and they are contraindicated. So these you could use implants, but undiagnosed genital bleed, implants, basically progestins are contraindicated. And there are other 2 conditions also where progestins, again progestins are not to be used, not preferable, is acute liver disease and decompensated cirrhosis. These are 2 conditions where the progestins are category 3 in general, okay? So now we finish off the recall. So there were a lot of questions that we discussed. At the end, I will come back to what I started the recall with. Your primary areas of focus for your upcoming exams, now let me tell you, has to be the previous year topics. When I say previous year topics, you have to be thorough with them. Okay, focus on the clinical concepts. Okay, avoid the tendency of ratification. Okay, more and more they are asking you clinical based questions. All right, facts are something obviously you and I both need to mug up. So facts are something that you will mug up, that is for sure. But you will have to go through the main lectures. If the main lectures are too exhaustive, in the sense that obviously I agree that you have all these different subjects, 19 subjects to prepare, OBS-Gynae being a huge chunk of your examination questions cannot be taken lightly. So go through the main lectures for the previous year topics. At least, even if you're not watching the main lectures completely, you can obviously focus. You can, my strategy would be to begin with the rapid revision, but where more and more clinical aspects are involved, go back to the main lecture videos. So you can go retrospective approach, go back to the main lectures and look at that portion. Like, for example, I would say that the clinical topics like amenorrheas or clinical topics like abnormal uterine bleeding, those are some things that you should discuss, you should read from the main lectures also, where clinical approaches are discussed in detail. Okay, so you can attempt the questions and you can look at the rapid revision videos. There are many areas in rapid revision videos where I keep telling you that this topic also needs to be done from the main lecture videos. So by that logic, by that way, you can go back to seeing the main lecture videos if you find that yourself, if you find that you are short of time and you're not able to see the main lectures completely. That strategy you can go for, right? But you will have to be thorough with the previous year topics. Now, just mugging up one-liners and just mugging up questions won't help, because the options are very close. Different permutation combination of clinical scenarios are asked, right? So keep that in mind as your strategy going forward for your upcoming exams. Thank you so much.